I will speak about the nephrotic syndrome. Nephrotic syndrome. There is what? There is massive proteinuria, more than 3.5 gram per day. More than 3.5 gram per day. So it's a damage to what? Damage to the podocytes. Damage to the podocytes. So the first disease is what? Minimal change disease. Minimal change disease. It's called what? Lipoid nephrosis. Lipoid nephrosis. Most common cause of nephrotic syndrome in what? In children. Children is so important. So children with nephrotic syndrome, massive proteinuria, more than 3.5 gram per day. So it's what? Minimal change disease. Minimal change disease. So primary cause, it's what? Idiopathic. Four eyes for minimal change disease. Idiopathic may be triggered by what? Infection, immunization, immune stimulus. So minimal change disease by what? By four eyes. Idiopathic, infection, immunization, immune stimulus. So it's really maybe secondary to what? Lymphoma, cytokine mediated damage to what? To the podocyte, leading to nephrotic syndrome, leading to heavy proteinuria, more than 3.5 gram per day. Then primary disease has excellent response to what? To glucocorticoid. So this is so important. So in children, nephrotic syndrome with heavy proteinuria, more than 3.5 gram per day in children, and there is excellent response to what? Glucocorticoid. Plus on light microscopy, immune fluorescence, electron microscopy, light microscopy, normal glomeruli. Lipid may be seen in what? Proximal tubule cells. Immunofluorescence, negative. Electron microscopy is so important. Effacement of podocyte food process. So this is effacement of podocyte food process. So in minimal change disease, in nephrotic syndrome, you must remember three. What are the three? Children, excellent response to what? Glucocorticoid, effacement of podocyte food process. So again, minimal change disease, you must remember that nephrotic syndrome with massive proteinuria, more than 3.5 gram per day in children, excellent response to what? To glucocorticoid, plus effacement of podocyte food process. Then the next one, focal segmental glomerulosclerosis, higher prevalence in what? Black people. So maybe primary idiopathic, or secondary to other conditions. So you have what? H and other H. So it's what? It's heroin, high body mass index. Body mass index means what? Obesity. So heroin and high body mass index, obesity, and HIV infection, sickle cell disease, interferon treatment, congenital malformation. So focal segmental glomerulosclerosis, it's a secondary to what? To HIV infection, sickle cell disease. To H, heroin, high body mass index means obesity, interferon treatment, congenital malformation. Primary disease has inconsistent response to what? To steroids. So may respond and may not, so it can progress to what? To chronic kidney disease. Then on light microscopy, immunofluorescence, electron microscopy, light microscopy, it's called what? Focal segmental. So it's a segmental sclerosis, hyalinosis. So segmental sclerosis, hyalinosis. This is on light microscopy. Immunofluorescence, mainly negative, and may be positive for non-specific focal deposit of immunoglobulin M, C3 and C1, but it's often what? Negative. On electron microscopy, there is what? It's like minimal change disease, there is effacement of food process, so focal segmental glomerulosclerosis. A rapid revision for it, higher prevalence in black people, maybe idiopathic primary, maybe secondary to other causes like HIV infection, sickle cell disease, 2H, heroin, high body mass index means obesity, interferon treatment to congenital malformation, and primary disease, it's what inconsistent response to steroid, may respond and may not, so can progress to what chronic kidney disease. Then the main one is what it's called what focal segmental, so segmental sclerosis hyalinosis, then immunofluorescence mainly negative. If it's positive, so it's for non-specific focal deposits of what immunoglobulin M and C3 and C1. Electron microscopy, there is what effacement of food process like what minimal change disease. Then this is the main one, membranous nephropathy, called what membranous glomerulonephritis. So membranous glomerulonephritis, membranous nephropathy, can be primary due to what the antibodies to phospholipase A2 receptor, and this is so important because he will ask you about this case. This is a normal case of nephrotic syndrome with heavy proteinuria more than 3.5 gram per day, and he will ask you there is positive antibodies against phospholipase A2 receptor. So what is this case? The case is membranous nephropathy, the case is membranous glomerulonephritis. So antibodies against phospholipase A2 receptor, this is called what? Membranous nephropathy. Membranous glomerulonephritis. And you must remember what? It's associated with what? Hepatitis B, hepatitis C, and solid tumors. So it's asked in the exam: hepatitis B, hepatitis C, and solid tumors. This is a case of membranous nephropathy, and secondary to some drugs like what? Non-steroidal anti-inflammatory drugs, penicillamine and gold. But you know that the sulfa drug associated mainly with what? Interstitial nephritis. So non-steroidal anti-inflammatory drug, penicillamine associated, and sulfa drugs associated with what? Interstitial nephritis, and it's associated also with what? Membranous nephropathy. But you must remember what? In membranous nephropathy, antibodies against the phospholipase A2 receptor plus what? Hepatitis B, hepatitis C, and solid tumor. If he asked you about heroin and high body mass index, obesity, so heroin was what? Was focal segmental glomerulosclerosis. But hepatitis B, hepatitis C, hepatitis C, solid tumor is so important. So he will ask you about finding in the patient was what? With solid tumor with nephrotic syndrome. So what is the case? It's a membranous glomerulonephritis. So hepatitis B, hepatitis C, solid tumor. So it's associated with antibodies against the phospholipase A2 receptor, and secondary to drugs like non-steroidal anti-inflammatory drugs, penicillamine, gold, and infection like hepatitis B, so important, hepatitis C, so important, and syphilis, and also solid tumor, so important. Solid tumor was what? Membranous nephropathy. Hepatitis B, hepatitis C was what? Membranous nephropathy. Antibodies against phospholipase A2 was what? Was membranous nephropathy. Then systemic lupus erythematosus. The most common cause of this is what? Lupus nephritis. So it can be caused by drugs, and there is a marker for it: antihistone antibody. So drugs like what? Hib, hydralazine isoniazide broconamide. This is in case of drug-induced lupus. Antihistones, but systemic lupus that will cause nephritis, that will lead to this systemic lupus, anti-nuclear antibody. This has a high sensitivity. Then there is another test, anti-double-stranded DNA. It's very specific, anti-double-stranded DNA for systemic lupus erythematosus. So you must remember what hepatitis B, hepatitis C, solid tumors, antibodies against phospholipase A2 receptors. This means what? Membranous glomerulonephritis, membranous nephropathy, and of course thromboembolism. In any case of nephrotic syndrome, it can come with what? It can come with hematuria. How? There is loss of antithrombin 3, leading to high coagulability, leading to what? Thromboembolism, DVT, renal vein thrombosis, and leading to hematuria in patient with nephrotic syndrome. So any case of nephrotic syndrome can come with what? Hematuria. Why? Because there is loss of antithrombin 3, leading to hypercoagulability, leading to thromboembolism and DVT and renal vein thrombosis, and leading to hematuria in the case of nephrotic syndrome. And also there is a loss of what? Immunoglobulin G, loss of immunoglobulin G, leading to what? Leading to high susceptibility for infection. Then there is what? Primary disease has poor response to steroid, and this is so important. Why? To differentiate between these two types. Minimal change disease, excellent response to what? Glucocorticoid, but membranous, it's what? Poor response to steroid. So again, minimal change disease, it's what? It's excellent response to glucocorticoid, but membranous, it's what? Poor response to steroid, may progress to what? Chronic kidney disease. Then on light microscopy, immunofluorescence, electron microscopy is so important. Spike and dome appearance. On light microscopy, there is what? Diffuse capillary glomerular basement membrane thickening. So diffuse, there is what? Glomerular basement membrane thickening, diffuse capillary thickening, and diffuse glomerular basement membrane thickening, diffuse capillary thickening. So there is what? Diffuse capillary thickening and glomerular basement membrane thickening. Immunofluorescence, it's what? Granular. Why? Because there is immune complex deposition. So it's granular. Electron microscopy, this is the most important. So spike and dome, subepithelial. So you must remember these cases. It's what? It's membranous nephropathy. So it's what? Spike and dome, subepithelial. So it's a membranous nephropathy plus granular immune complex. But the most important is what? Subepithelial, spike and dome. This is the most important. Then this is so important also. Poor response to steroid, because minimal change disease has excellent response to steroid. Poor response to steroid. Plus it's a case with what? Hepatitis B, hepatitis C, solid tumor, plus antibodies against phospholipase A2 receptors. This is membranous. Then the next one, systemic disease, amyloidosis. So kidney is most commonly involved organ in what? In amyloidosis. It's called systemic amyloidosis, associated with what? Chronic conditions that predispose to amyloid deposition, like AL amyloid, AA amyloid, prolonged dialysis. So in the stage renal disease, there is what? Prolongation for dialysis. This dialysis leading to what? Leading to, as a patient will come with carpal tunnel syndrome due to deposition of amylin surrounding what? Surrounding the median nerve, leading to what? Carpal tunnel syndrome. So prolongation of dialysis in the stage renal disease will come with what? Carpal tunnel syndrome due to deposition of amylin. In case of amyloidosis, deposition of amylin surrounding the median nerve, leading to what? Leading to carpal tunnel syndrome. Then there is what? On light microscopy, there is what? Congo red stain, apple green birefringence. So apple green in case of what? Amyloidosis. This is so important. So amyloidosis in the stage renal disease, dialysis plus what? Apple green birefringence, apple green Congo red. So apple green Congo red. This is a case of what? Amyloidosis under polarized light due to amyloid deposition in the mesangium. So the most important is what? Congo red stain, apple green plus prolonged case of dialysis, end stage renal disease, carpal tunnel syndrome, and AA amyloid and AL amyloid. Then the next one is what? The most important, diabetic glomerulonephropathy. So diabetic glomerulonephropathy is what? Most common cause of end stage renal disease in United States. So hyperglycemia will lead to what? Non-enzymatic. So there is no enzyme glycation of tissue protein, leading to what? Leading to mesangial expansion and glomerular basement membrane thickening and increased permeability. So the most important is what? Increased permeability leading to hyperfiltration, glomerular hypertension, and increase what? Glomerular filtration rate. So you will check for what? Microalbuminuria, microalbuminuria. So microalbumin in the urine. For this case, the diabetes will affect what? Will affect the kidney, leading to end stage renal disease. So there is what? There is hyperglycemia leading to non-enzymatic without enzyme glycation of tissue protein, leading to mesangial expansion and glomerular basement membrane thickening and increased permeability. This increased permeability leading to hyperfiltration. So the disease associated with what? Hyperfiltration leading to increase the glomerular hypertension, increase in glomerular filtration rate. This increase in glomerular filtration rate leading to increased glomerular hypertrophy and glomerular scarring, leading to glomerulosclerosis. So hyperfiltration leading to glomerulosclerosis. So we have afferent and we have the efferent. There is what? Angiotensin 2 affecting the efferent. So you will treat it with what? ACE inhibitor to inhibit angiotensin 2, which is causing vasoconstriction of the efferent, leading to what? Vasodilatation of the efferent, leading to decrease the hydrostatic pressure in the glomeruli, leading to decrease the glomerular filtration rate, decrease the hyperfiltration, decrease the glomerulosclerosis associated with diabetic glomerulonephropathy. So again, angiotensin so ACE inhibitor will inhibit what? Angiotensin 2. Angiotensin 2 is responsible for what? Vasoconstriction of the efferent. So by inhibition of it, leading to vasodilatation of the efferent, leading to decrease the pressure in the glomeruli, decrease the filtration. So decrease this hyperfiltration, decrease the glomerulosclerosis, leading to prevention of the progression of the disease. So if there is hyperfiltration and if there is increase in glomerular filtration rate, increase glomerular hypertrophy and glomerular scarring, leading to glomerulosclerosis and progression into what? Progression of nephropathy. Then on light microscopy, there is what? Mesangial expansion, glomerular basement membrane thickening, and eosinophilic nodular glomerulosclerosis. This is so important in case of diabetic glomerulonephropathy. Nodular glomerulosclerosis has a name. It's called what? Kimmel-Still-Wilson nodule. So Kimmel-Still-Wilson nodule. This is Kimmel-Still-Wilson nodule. Kimmel-Still-Wilson nodule. So it's called what? It's called eosinophilic nodular glomerulosclerosis. Kimmel-Still-Wilson nodule. So you have, in case of diabetic glomerulonephropathy, you have what? In case of diabetes that will affect the kidney, leading to what? End stage renal disease. Kimmel-Still-Wilson lesion. Kimmel-Still-Wilson nodule.